Hi, everybody. Sorry for the break in our um, presentations last week. I wasn't able to do one. And I just want to thank Dr. Trisha Paul again. She gave us quite a few good presentations over the last few weeks. It took quite a bit of pressure off me as well. And I think I got a bit lazy. I didn't do one last week. But anyway, I actually came across an interesting case study that I wanted to go through with you guys. It actually forms part of our morbidity and mortality. And it's quite an interesting case. It is a bit involved. And it is something that's not as common, but that's just very interesting. So it's one of those ones where you can kind of switch off your brain a little bit and just listen. But, you know, if you retain some of the pertinent points, it will help you a lot later on in your practice. Okay. So what we had was a 54-year-old male patient who presents in acute cardiogenic shock. All right. So why we say the patient is in shock is because we've got low BPs with evidence of low cardiac output. All right. So that's how you decide that the patient's in acute cardiogenic shock. They're not in septic shock. They're not in neurogenic shock. They're not in hypovolemic shock or anything like that. Basically, the heart is unable to push out so there's left ventricular failure, bilateral failure, what you would call congestive cardiac failure. So this patient had signs of congestive cardiac failure. And so he was in left heart failure clinically. So what does that mean? He had bilateral basal creps. It didn't indicate how high up the creps went, but that he did have evidence of left ventricular failure. Now, remember, failure and shock are symptoms. They aren't diagnoses. It's like putting cough or pain. These are symptoms, but it doesn't actually tell you what's going wrong. And that's why I actually found this one quite interesting. All right. So the thing is, even though he was in left ventricular failure, at least the doctor had seen the patient, noted an extremely strong apex beat that wasn't displaced, all right, which is quite odd. So if you had to stop there and just start thinking, you think to yourself, okay, we've got this heart that's beating. I mean, it's even though the patient looks like they're in left ventricular failure, but you have this heart that's beating very hard. Okay. Now, it's not left ventricular hyperplasia because it's not displaced. So is there evidence of hypertrophy? Yes, there's a strong apex beat, but why is there hypertrophy? So this is where the interesting part should come along. So what is happening? So do I have a problem with my outflow? Do I have a problem with my inflow? So my inflow is from my left atrium and my, what you would call it, mitral valve. So is there a problem coming from there? Do I have left atrial hypertrophy? Is that what's causing extra blood to be moved in? Do I have left atrial, mitral regurg? Is that what's going on? Do I have aortic, a problem with the aorta or with the aortic valve? So these are the things that you should immediately start thinking about. So what they did was they gave him a bit of Lasix, but he didn't really show much response. And considering he's 54, one of the other things, of course, you consider is a myocardial infarction. There's quite a bit that you would think about when it comes to this, all right? So this patient continued to deteriorate despite anti-failure measures. So that means he continued going down. They were giving him Lasix, they were giving him aldactone, and it wasn't improving. So I think they had discussed with medicine, and due to his patient's age, they decided, okay, let's give him a chance, and he was actually going to be sent to ICU. And he was started on single strength adrenaline, and he showed marginal improvement. In other words, the BPs came up and things like that. The ECG was marked as NAD, all right? So no abnormalities detected by the initial doctor who saw the patient, and cardiac enzymes were negative. So remember, within the first 6 hours of an MI, your cardiac enzymes can be negative. So, it can happen like that. Sorry, I didn't realize we were in the small version. And it is a difficult diagnosis because now you've got to think about where the problem may be. So how do you decide where the problem is now? So there's a few ways. Number one is with your ECG. Number two is with your hands and with your ears, your stethoscope, things like that. And then we've got more modern modalities now. So even of course, you could do your pro-BNPs. You could look for underlying signs of, endocardial disease, myocardial disease, things like that. And of course, you've got ultrasound. There's quite a bit that's there. Okay, so let's look at the ECG, and then let's just have a look at what we find. All right? So the first thing is that we see we've got a normal what you call it, axis. The rhythm itself was relatively normal. Okay, the rate itself was also not too high. It was about 70 somewhat. Now, for those of you who may be lost, who may be new, please go back and look at the older lectures on how you get to all of this. It will help you quite a bit. Now, even in just glancing through, we'll see that there's a few things that are going on. So if we look at the inferior side of the heart, number one, the first thing we notice are these little Q waves. Now, they're not pathological Q waves because they're not deep, not wide, but they are there. If we come to lead 3, we start to see this ST depression with an inverted T wave. We have an inverted T wave there. And in the AVF, which is the last part of your inferior, you also see the slight T wave inversion, maybe even a what you call a biphasic T wave. Now, this could indicate ischemia. It's very possible. Okay. Then, if you look at the right-hand side of the heart, we start to see, I mean, the AVR, we start to see this little RSR complex, which is abnormal. We normally get a QR, what do you call it? A QR wave. That's the normal way that it goes. If we were to look at the septum, so V1 and V2, what we start to notice is that, again, we've got this RS complex, which is quite big, you know. And once we start coming to V3 and V4, which are the what you call it, the anterior leads, we start seeing these Q waves again. Now, these Q waves are quite deep, even though they're not wide, but they're quite deep. And this is an indication of a pathological Q wave. So ischemia is still there, but this doesn't necessarily point to ischemia as well. And in V5, V6, our lateral leads, and in 1 and AVL, again, our high lateral leads, where we're looking at the lateral side of the heart, we start seeing this Q waves again, although their progression gets a bit less, we do see them. So the question is, what's causing these Q waves? What's causing this abnormality in conduction? All right. So if we had to look at lead V1, all right, we are looking at lead V1, which is essentially looking at the right side of the heart in the septum, if you remember some of our older lectures. So it can't really see the left ventricle normally. You can't normally see the left ventricle, similar to what you get here. You can't normally see the left ventricle. But what's happening is there's a large amount of energy that's moving away from V1. It's actually catching the left ventricle just a little bit. So and even from what we got clinically, it tells us something's happening in the left ventricle as well. Now, these Q waves, or this particular type of Q wave, is quite specific for one particular problem. And it's quite particular for hypertrophic obstructive cardiomyopathy. All right? Hypertrophic obstructive cardiomyopathy. Now, already that sounds quite a big word, right? We call it HOCM for short, right? And HOCM is basically an overgrowth of the myocardium within the left ventricle. Okay, some of the other features that you can see are these biphasic T waves in your lateral leads. That's one of the other ones that you can see if you don't see the Q wave. But this is the more common one that you see. Now I'm going to try and explain HOCM to you, hopefully, so that it's something that, especially if you're a junior doctor and it's something you can pick up, it's quite impressive. All right. So hypertrophic obstructive cardiomyopathy. Let's start with that. Right. So what you have over here is you have the left ventricle. Now we are actually looking at the CT. All right. You know, it's what we are seeing here is the left atrium. We are then seeing the left ventricle, right? And we should be getting a, what you call it, aortic valve coming out from here as well. Okay. So what happens is there's just this overgrowth of tissue compared to a normal heart, right? So that's basically what it means, all right? Now, this is something that often goes in with it. It's called systolic anterior movement of the mitral valve, or SAM, all right? Now, what that means is when there's what you call it systole, in other words, when the two ventricular walls are coming together, you shouldn't have an anterior movement of your mitral valve. But if you watch it here, you can see it goes forward. All right, so this is something called HOCM with SAM. Now, this is something that senior doctors will sometimes throw out and say, this could be HOCM with SAM. And you look at them and say, oh my God, is that something you order from KFC? What the hell is that? All right, so, this is what it means, hypertrophic obstructive cardiomyopathy. I'm going to explain it in more detail. So it's not a common diagnosis. It does respond to inotropes, and the cause of death is normally due to outflow obstruction, which I'll get to in a minute. It's quite common in steroid users. So as we know, there's an epidemic of anabolic steroid use. Right? Now, there's a lot of things, social media, social pressure to look good, to have, a particular type of body and things like that. So a lot of people are resorting to steroids in those cases. In some cases, it is financial as well. They earn from some of the social media sites, so they're more incentivized, to use these drugs. And unfortunately, even though it causes hypertrophy of your general skeletal muscle, it also causes hypertrophy of your cardiac muscle. Okay, so it's quite important in steroid users. Okay. So let's have a look at it. So we're just going to get into it. So what causes hypertrophic cardiomyopathy? So there's a few: genetic, storage, neuromuscular and mitochondrial disorders, malformation syndrome. Now, if you have a chance, you can go through all of these. And if you are one of those people who's going to become a physician, then you really need to know all of these. All right, it's quite a common question, and you need to know exactly what's going on. All right, so you can see it's quite involved, and if you really had to go into hypertrophic cardiomyopathy, it's an entire section on its own. All right, so let's have a look at what's going on. So what happens with it? So let's have a look and see. So this is where the problem comes about. Okay, so you've got this large thickened septum, well, essentially the left wall, all right, and you have an increased ventricular thickness. So you have your left atrium, right ventricle, left ventricle, mitral valve, and aortic valve. So what's happening is that when you're having systole, when these two are moving together, it's actually blocking off outflow. So it's an outflow obstruction into the aorta, right? Which we're going to have a better look at in a little while. But I just wanted to explain to you that that's what's going on. So what's going to happen? As you get that, number one, like I said, because of this hypertrophy, it actually pulls the, it actually pulls the valve forward, right, as it's moving together. And then you have this large ventricle that is unable to push as much fluid. So eventually you can also develop stenosis, and it's quite, incompetence, mitral incompetence. So it's very common for the blood flow to now start moving backwards. It dilates your atria, and then if you go backwards into the lung, it then leads to signs of left heart failure. Right? And that backflow has to eventually go somewhere. So it goes to the right ventricle, all right? And there you can see the right ventricle becomes, it almost gets indented by the left ventricle. And eventually that also causes a backflow into the right atrium and into the IVC. Okay, so so you can see right up to right heart failure and congestive cardiac failure in these patients, all right? So let's have a look at it and see what happens. So why do these patients die? All right, now what do you get from history? Family history of sudden death is something that needs to be sought after. Unexplained syncope, which can also be due to aortic stenosis, or it can be due to hypertrophic or HOCM itself, right? So abnormal exercise blood pressure response. So when they are exercising and as the heart needs to beat faster, they, cause more outflow obstruction, and eventually they collapse, all right? Then they may have severe left ventricular hypertrophy as well, non-sustained ventricular tachycardias, which are wide complex ventricular tachycardias that don't persist. Right? So these are some of the things that you may see. Oh, sorry. Okay, so this picture explains to you better what's going on. So as you can see, once you get outflow obstruction with the hypertrophied wall, you don't get enough outflow. It's basically the heart blocking itself off from, from allowing blood to go into the aorta. That's basically what it is. And the definitive treatment for it is myomectomy. Now, myomectomy merely means the removal of that tissue. And if you've ever have a chance to sit on those procedures, they're really something to see. Number one, the setting up of the bypass. Number two, the amazing cleanliness of the heart on the inside. You understand why it's how the body is sterile sterile on the inside when you see this, And once the myomectomy is done, you can see now you have an outflow tract. So as the heart contracts, it now has space to send the blood through, instead of the blood being trapped and small amounts being pushed through. So that's basically what happens during HOCM. And like I said, very often HOCM, or hypertrophic obstructive cardiomyopathy, is associated with systolic anterior movement of the mitral valve, all right, which is something you'd only see on echo, or you'd see on a CT of the cardiac muscle and things like that. So it just goes to show you that sometimes CCF is much more involved than we expect. We're quite, most of us, even myself too, we're quite just say, oh, it's CCF, put them in the ward, give them a bit of Lasix, they'll be all right, some diuretics, let's see what it is. But if you're not sure, if something seems strange, like in this case, it was a young person, relatively speaking, to be in CCF, but if there's something that's just making you feel a bit nervous about it, ask for a bedside or do a bedside echo, get a formal echo. And if you're in the peripheries and you have a CCF not responding, and you see these ECG changes, then you transfer these patients immediately. It's amazing how easy it is to sort out once it's picked up. Majority of the patients don't reach that stage of sudden death without having presented a few times with particularly CCF, exercise intolerance. There's a few things, syncope, and then they eventually get to this point. And if you go track back in their histories, you normally see they presented a few times. They might even be on chronic treatment for CCF and things like that, but they haven't had any improvement. Okay. All right. So I hope you guys enjoyed it. Apologies for the phone in the background. And if you have any questions, more than welcome to message me. And hope you enjoyed it, and we'll have another one next week. Okay, bye.